That was a fantastic talk, John, and that really made a lot of the points that I was going to address in my talk related to the complexities of pathology, the subjectivity, the difficulties, particularly in patients with small volume disease, of making a firm diagnosis. And it's a shift really towards the concept of volume assessment rather than a strict reliance on Gleason score in terms of making rational treatment decisions. So just first of all, a quick point about natural history. This is from the large multi-center series, post-prostatectomy with pathologic staging based on radical prostatectomy. So this is the one study that gets around a lot of the issues of undergrading that you see in conservative management series. They're all pathologically staged. Gleason 6, essentially no deaths at 20 years. Gleason 7, just to emphasize the point, in middle-aged men, the majority of men, even at 20 years, of course, treated surgically, but the risk of prostate cancer death is relatively low in this group. So we have some wiggle room. This is Gleason 3 plus 4. The presence of a little bit of Gleason 4 doesn't confer that much of an increased mortality. Again, this is in men treated surgically, but it's just a guide to how aggressive this disease is. Treatment has morbidity, that's the problem, erectile dysfunction, incontinence. Fine if you're treating an aggressive disease, it's really life-threatening, but not really acceptable if you're treating a very indolent disease. I just want to emphasize the point about surveillance because it applies to patients not just with the very lowest grade, but other patients who want to maintain quality of life, that the primary aim as compared to watchful waiting in patients fit for radical treatment, individualized management, identify the bad actors as early as possible with curative rather than palliative intent. The other key point, I think, is that patients don't necessarily live as long as we expect they might. So if patients have significant comorbidity, and Mark Litwin addressed this very well, if patients have significant comorbidity, this is the lower quartile of general health status. At 65 years old, these patients only have an 8 to 9 year life expectancy. So even with Gleason 7, at 8 to 9 years untreated, the prostate cancer mortality is quite low. At age 70, 6 to 7 years. So you identify these men who have significant underlying comorbidity, and it may be very reasonable, even for a man in their 60s, to offer a conservative approach for intermediate risk disease. But more to the point, we want to make sure that we're identifying patients who really have the bad actors for treatment. And John addressed many of the issues around the modification of the Gleason scoring system, but I just want to emphasize one more point, and I alluded to this last night. The modified system incorporates any Gleason 4 or 5 into the pattern. So if it's 95% 3 plus a tiny bit of 4 or 5, you get a 7 or an 8. And here is the problem. Tangential cutting of a Gleason 3 acinus. So here is a patient, level 1. Pathologists would look at this, they don't see acini, and they call it a 4, particularly if it's a small volume cancer. They cut deeper and you start to see acini and it becomes a 3. So you're really dependent on the pathologist taking this very seriously. Here's one recent study of this. In patients who are candidates for surveillance, 25% of them fell into this category with these tiny bits of glands. The pathologist is not sure how to call them. The concordance was 27%. So this foundation of pathology is really a swamp. The pathologist is giving us a number, but what does it actually mean? It doesn't mean a lot, and we should incorporate that uncertainty into the decision making. And John also referred to this paper that showed, as a result of this modification, the percentage of Gleason 7 has skyrocketed. This is not the Gleason 7 that we are used to thinking about. This is a disease that it covers a range of patients from very, very indolent to very aggressive, and that uncertainty is important. Now, in fact, there are 3 studies that have looked at the effect of surveillance on Gleason 7, and the presence of 7 is a predictor for progression. One is ours. We published this quite a while ago. This was our early experience where between 1996 and 2000 we included patients over 70 with Gleason 3+4. We stopped doing that in about 2000 for two reasons. One, we were getting tremendous criticism as this was an unethical practice. And two, we wanted to keep our cohort a little cleaner with just Gleason 6. But amongst those roughly 50 patients with Gleason 7, the Gleason score was not predictive of progression, clinical progression, or treatment at all, completely non-predictive. The second major series is from UCSF, Cooperberg and Carroll. 90 men with intermediate risk disease, either a PSA above 10 or Gleason 7 or higher. No difference in any outcome. In fact, the intermediate risk patients on surveillance do better in terms of progression-free survival than the Gleason 6 or PSA less than 10. So again, these somewhat arbitrary cutoffs don't seem to translate into a difference in progression rate. The third series, same concept from the Prius group in Rotterdam, 50 men with Gleason 7, most of them 3+4, and they stratify into those who fulfill Epstein criteria, except they've got a little bit of 4. So, 2 cores, low PSA density, et cetera. And look at that. The percent untreated for the group who fall into the favorable pathologic cohort, just a little bit of cancer with Gleason 3+4, really no difference than any other surveillance curve in terms of the proportion treated. If anything, it's better. And no deaths at all from prostate cancer in that group. And then finally, we've heard a little bit about MRI, and you incorporate MRI into this algorithm. So you take the patient who has 3 plus a little 4, you do the MRI, there's a fairly tight correlation between the diffusion-weighted image and the Gleason grade, and you have a negative MRI in this patient, and it really gives you fairly good confidence that he does not have a significant volume of high-grade cancer. And then finally, you've got the alternative of focal therapy, which could be called active surveillance plus, where you're just treating the index lesion, you're not worrying about the little bit of Gleason 6, and you continue to follow the patient, do serial biopsy or perhaps MRI. And this is a way of avoiding radical treatment and managing this patient with minimal morbidity. So I think, when is surveillance appropriate for Gleason 3+4? Both in healthy men who have small volume disease and a low percent 4. And I think, as John just alluded to, your pathologist should be providing some information about the percent 4. It's not enough to say Gleason 3+4. You want to know, is it 5% 4 or is it 40% 4? And consider this tangential cut issue as an explanation if it's only a very small amount of 4, and make sure your pathologist has done the sequential cuts through the block to try and rule that out. I think MRI is very useful in this situation to ensure that you've not assessed the extent of disease, preferably stable PSA, recognizing the limitations of PSA, and for patients in whom quality of life is a priority, and this is clearly an issue particularly for younger patients. And then, of course, there's also patients with significant comorbidity, 65 and older, for whom their life expectancy is likely to be less than the natural history of their disease. Thank you.